Today, we're going to explore the laboratory evaluation of bleeding and clotting. These tests are cornerstone of diagnosing coagulation disorders, monitoring therapy with anticoagulant drugs, and identifying causes of both excessive bleeding and excessive clotting. As we move through this lecture, we'll look at the major lab tests, what they measure, and how to interpret abnormal results. And by the end, you should feel confident in linking clinical findings with the appropriate coagulation studies. When we order a coagulation profile, we typically include three key elements: the partial thromboplastin time, or PTT, the prothrombin time, or PT, and the platelet count. Together, these tests give us a snapshot of how the coagulation cascade is functioning. PT reflects the extrinsic and common pathways. APTT reflects the intrinsic and common pathways, and the platelet count helps us evaluate primary hemostasis. In practice, this trio provides the foundation for understanding whether a patient is at risk of bleeding, clotting, or both. The activated partial thromboplastin time, or APTT, is one of the most widely used coagulation tests. It assesses the intrinsic and common pathways of the coagulation cascade. Clinically, it's most useful for monitoring patients on heparin therapy since heparin acts directly within these pathways. A normal value, as seen on the slide, ranged from 30 to 40 seconds, with a broader PTT range of 60 to 70 seconds. If values are prolonged beyond critical thresholds, patients may be at significant risk for bleeding. When interpreting the APTT, context is everything. A prolonged APTT may reflect inherited clotting factor deficiencies, such as hemophilia, but it also may be due to acquired causes like cirrhosis, vitamin K deficiency, or disseminated intravascular coagulation. Importantly, heparin therapy will prolong the APTT, so we deliberately monitor this test when titrating heparin doses. On the other hand, a shortened APTT can appear in conditions like early disseminated intravascular coagulation or certain cancers, which may reflect hypercoagulable states. Collection for an APTT test is straightforward. No fasting is required, and the sample is drawn into a blue top tube which contains sodium citrate. The citrate prevents clotting in the tube, preserving the factors for analysis. Correct collection and handling are critical because coagulation factors degrade quickly at room temperature, and mishandling can lead to falsely abnormal results. When we review a patient's APTT, we consider both increases and decreases. Increased times can occur in congenital deficiencies, vitamin K deficiency, liver disease, DIC, or as a result of anticoagulant medications like heparin or coumarin. Decreased times, though less common, can point to early stages of DIC or an extensive malignancy. Interpretation always requires putting the lab value into the bigger clinical picture of patient history and current therapies. When we come back, we will look at prothrombin time.